Well, good evening, everybody. It's 6 o'clock, and I'm beginning to feel like I'm reading the news at 6 o'clock. It's become such a part of the week, and we've all got used to joining together for this series of webinars. I have to say, I think this evening's webinar is possibly the most important one that we've had over the last 6 months. And it deals with the new surgical curriculum that's going to impact all of our trainees and all of our surgical trainers. It is an extraordinary body of work. I think it will lead to improvements in assessment. It will allow earlier identification of difficulties, but also it will facilitate remediation of these difficulties, which I think is quite the most important aspect of it. So we have three speakers this evening: Oscar Trainee, Dean of Postgraduate Surgery, Surgical Education and Training in RCSI. I'm delighted to welcome Dr. Amy Lee Fowler, who's a Specialist Registrar in Vascular Surgery and the Irish representative on ASIT, who's going to talk about the trainees' perspective. And I hope Professor Paul Balfe is going to join us. I don't see him online.
I'm here, President. Yeah, thanks.
Oh, you're there, Paul. Great. Okay. And Paul is going to then talk about the trainer's perspective. And I'm sure, Paul, you're going to dwell a little bit on training people, the need to train people for the jobs that they are going to face on a day one of their consultant position, and the broad training that is needed, as well as the specialty training. So I think it'll be a very interesting evening to get the perspectives from all three. Then there'll be a question and answer session, and as is usual, can I ask that you would use the chat function, and I will try and put as many of the questions as possible to the trainees, and we hope to have it all wrapped up shortly after 7 o'clock. So Oscar, I'd be very pleased if you could give your presentation.
So good evening, everyone, and apologies for the slight hitch there getting started. So my name is Oscar Trainee. I'm the Dean of Postgraduate Surgical Education and Training in RCSI, and I am also the RCSI representative on the management group of the Intercollegiate Surgical Curriculum Programme. So I've been quite heavily involved in the development of the new curriculum and in the implementation plan for the new curriculum. So what I'd like to tell you about this evening is just to give you an overview of the major changes which will be taking place in the new curriculum, which will be introduced here in Ireland on the 12th of July, just 2 weeks from now. Next slide, please, Pauline. So a curriculum is an essential part of any training program. The curriculum is what defines the structure of training and also describes the expected outcomes of a training program. The curriculum also includes what will be learned in the program, i.e. the syllabus. It also describes how the program will be taught, that is the pedagogy, and how it will be assessed, that is the assessment framework. And finally, the curriculum describes the roles and responsibilities of trainers. Next slide, please. A curriculum is an essential part of the program. It's at the core of any training program. In fact, training without a defined curriculum is not really a training program. And so it'll probably come as a surprise to many of you watching this evening that before 2007, just 14 years ago, there was no clearly defined curriculum for the various surgical specialties in these islands. Next slide, please. And then in 2002, the Joint Committee on Surgical Training, or JCST, which is the overarching intercollegiate committee responsible for surgical training set up a working group to develop a curriculum for all of the surgical specialties. This working group had representatives from all 4 surgical colleges, including RCSI, and the working group was tasked with developing a common format for the curricula of all surgical specialties. This was a very large undertaking. It took 5 years to complete the development program, and the new intercollegiate surgical curriculum program was finally launched in August of 2007. Next slide, please. An essential and integral part of the new curriculum was the process of assessment, and particular emphasis was placed on what became known as workplace-based assessments, of which there were various different types. Some of these WBAs looked at the knowledge, judgment, and skills of trainees, such as the case-based discussion, the clinical evaluation exercise, procedure-based assessment, and direct observation of procedural skills. Some assessments looked at the overall professionalism and professional behaviours as assessed by the multi-source feedback or 360-degree assessment tool. And then some looked at other components of surgical training, such as audit, observation of teaching, and observation of non-technical skills for surgeons. Next slide, please. The basic concept behind these workplace-based assessments was that they were analogous to building blocks. And the idea was that if you amassed a sufficient number of these building blocks and put them all together, next slide please, you would end up with a well-formed surgeon built on solid foundations. Next slide please. However, it soon became apparent that simply gathering a large number of blocks together and putting them together didn't necessarily end up with a well-formed surgeon on solid foundations. And it became clear that there were some basic problems with this concept of workplace-based assessments. Next slide, please. Firstly, it became a burden on both trainers and trainees. In many cases, trainees were expected to complete up to 40 of these workplace-based assessments in each year of training. And this was a real burden on trainers and also on trainees. But there was also a very obvious problem in achieving standardization of completion of these workplace-based assessments across the United Kingdom and Ireland. So while some trainers were very conscientious in completing the workplace-based assessments assiduously, others were much less lax or much more lax in the completion of these assessments. And so it became apparent that in a lot of cases, these workplace-based assessments became almost like a tick box exercise. And so about 3 years ago, it became clear that we needed to have a fundamental revision of the intercollegiate surgical curriculum program and look particularly at how we assess surgical trainees as they progress through the training program. Next slide, please. Around the same time, the General Medical Council in the UK brought about new standards for the development of postgraduate curricula in all medical disciplines, not just surgery. And they produced this document called Excellence by Design. And aligned with that, they developed this framework called Generic Professional Capabilities, which placed a major emphasis on the generic aspects of training rather than a long list of competencies which needed to be ticked. Next slide, please. The GMC designed its new standards, Excellence by Design and the Framework for Generic Professional Capabilities, and launched them in May 2017. And it was to help postgraduate medical training programs to refocus trainee assessment away from an exhaustive list of individual competencies and towards fewer broad-based capabilities required to practice safely as a day one consultant. Next slide, please. The GPC framework was developed by the GMC and the Academy of Medical Royal Colleges. And this is important because although we here in Ireland are not under the umbrella of the GMC, we are an integral part of the Academy of Medical Royal Colleges, and we do have representation and did have representation in the development of the new curricula. And the idea was that we would develop a consistent approach to ensure that all doctors demonstrate an appropriate and mature professional identity. The new framework prioritized themes such as patient safety, quality improvement, safeguarding vulnerable groups, health promotion, leadership and team working, and other fundamental aspects of professional behavior and practice. Next slide, please. Satisfactory achievement of the GPCs by trainees will demonstrate that they have the necessary generic professional capabilities needed to provide safe, effective and high quality medical care in the UK and the Republic of Ireland, and was firmly based on the concept of outcomes-based training. Next slide. As a result, the surgical training will now become outcomes-based, meaning that trainees will be assessed against the fundamental capabilities required of consultants during their working week in the management of acute call or acute take, managing inpatients, managing multidisciplinary team meetings, and importantly, the generic knowledge, skills and behavior required to be a good doctor. The end of training will be reached when supervisors agree that a trainee is performing at the level of a day one consultant. So this is giving a lot of power back to the training supervisors, the trainers, to use their professional judgment to decide when a trainee is ready to complete and finish their training. At the heart of these changes is the principle that the knowledge and skills necessary for everyday practice should be reflected authentically in the curriculum. And because of this, we'll be introducing a new assessment called the Multiple Consultant Report, of which I'll talk more later, encompassing the new concepts of the generic professional capabilities and the capabilities in practice. Next slide, please. So what I want to cover in my talk this evening are the underlying principles related to the generic professional capabilities and the capabilities in practice. I'll talk a little bit about some changes in the training structure, and particularly the concept of 3 phases of surgical training. I'll talk about the learning agreement, the index procedures, the notion of supervision levels, and then in some detail about the assessment system, including trainee self-assessment, and finally, the multiple consultant report. Next slide, please. So the generic professional capabilities underlie the curriculum for all postgraduate medical specialties, not just surgery. This is for all postgraduate medical specialties in the UK. And at the core of the GPC framework are professional values and behaviours. And surrounding this are the professional skills and professional knowledge. And interspersed then into the skills and knowledge are research and scholarship, education and training, safeguarding vulnerable groups, patient safety and quality improvement, leadership and team working, and health promotion and illness prevention. Next slide, please. The capabilities in practice are specific for surgical training. So the GPCs are common across all postgraduate medical training, but the capabilities in practice are specifically designed for surgical training. So the new curriculum describes fewer high-level outcomes of training, which are called these capabilities in practice, aimed at helping trainees to better understand what's expected of them in their training program. The CIPs operationalize and contextualize the syllabus under the main activities needed for independent practice at the level of a day one consultant. And they're therefore broader than the syllabus and will replace the syllabus as the main focus of assessment. When trainees are assessed as able to perform these essential activities independently, they are then considered safe and ready for certification and eligible for a consultant post. Next slide, please. The capabilities in practice, as I said, cover the main activities of the weekly working week for a surgeon: managing an outpatient clinic, managing unselected emergency take, managing ward rounds and inpatients, managing the operation list, and managing multidisciplinary team meetings. Next slide, please. The next change in the new curriculum is the concept of 3 phases in the training pathway. So phase 1 is core surgical training, a 2-year program, followed by national selection into phase 2, which is ST3 to ST6. And at the end of phase 2 of surgical training, a trainee should be able to perform all capabilities in practice to level 3 supervision. And I'll come to these supervision levels a bit more in a moment. And they should be eligible to sit the FRCS specialty examination in their specialty. There's an indicative allotment of 4 years to phase 2. And then there's what they call a critical progression point to the final phase, phase 3. And by the end of phase 3, trainees should be able to complete all CIPs to level 4. And this is an indicative 2 years. And this is followed by certification CCST in the case of Irish trainees. Next slide, please. The learning agreement is getting a lot more emphasis in the new curriculum. So the learning agreement is a formal process of goal setting and review meetings that underpin training, and it is formulated through discussion between the trainer and trainee at the beginning of the training rotation. The process ensures adequate supervision during training, provides continuity between different placements and supervisors, and is one of the main ways of providing feedback to trainees. There are 3 learning agreement meetings in each rotation between the trainee and the assigned educational supervisor, and these are recorded in the trainee's learning portfolio. Next slide. Now, I spoke already about supervision levels. Supervision levels, this concept is really important in the new curriculum. This is the trainer's assessment of what level a trainee is at in terms of their supervision that they require. So level 1 is where a trainee is only able to observe but is not able to execute any part of a task or function. Level 2 means that they're able and trusted to act with direct supervision, either with the supervisor present throughout or with the supervisor present for part. Level 3 is able and trusted to act with indirect supervision. And level 4, this is the really important one, this is where a trainee is able and trusted to act at the level of a day 1 consultant. This is the level that trainees must reach before they get signed off and get their CCST. Level 5 is able and trusted to act at a level beyond what is expected of a day 1 consultant. Next slide, please. Now, there is increased focus in the new curriculum on index procedures. They've been there before, but there's going to be an increased focus on index procedures, and in particular on achieving indicative numbers of the index procedures or critical conditions. And these are assessed by direct observation of procedural skills, DOPS, or procedure-based assessments, PBAs. Next slide, please. The assessment system is much more clearly defined. There is less emphasis on achievement of a set number of workplace-based assessments, and instead the WBAs are now optional activities for formative assessment of the trainees. There will, however, be some mandatory workplace-based assessments for the index procedures or critical conditions. Multi-source feedback will be as important as ever. Trainee self-assessment is a new concept which will be an important part of the assessment framework. And of course, we will continue to have the exit examination, the intercollegiate specialty examination. But a very important new part of the assessment system is this multiple consultant report, which feeds into the assigned educational supervisor report, which in turn feeds into the annual review of competence progression, or ARCP. Next slide, please. So the multiple consultant report is probably the biggest new part of the intercollegiate surgical curriculum. So this will take place at the midpoint and also at the end point of each placement, and will feed into the learning agreement. The MCR will involve the professional judgment of the clinical supervisors who work with the trainees on a day-to-day basis, assessing them against the high-level outcomes of the curriculum, that is, the generic professional capabilities and the capabilities in practice. So to make the multiple consultant report work, the consultant trainers with whom the trainee works are required to meet and to collectively form a considered opinion on the trainee's performance in that rotation. So we're putting the responsibility back onto the trainers to use their professional judgment in assessing the performance of trainees. Next slide, please. Completion of the multiple consultant report is very easy. It might initially seem like a large burden, a big burden on trainers. It is incredibly easy to complete it online. So on the left-hand side of the panel in the blue boxes, you see the 9 generic professional capabilities: professional values, professional skills, professional knowledge, and so forth. Then in the next column, there are 2 tick boxes. There's a choice of ticking either appropriate for stage of training or areas for development. If a trainer ticks appropriate for stage of training, there is no need to add anything else. However, if there are areas for development, then in the next box, we need to complete some comments as to what are the areas for development. And then over on the right-hand side in the orange boxes are the descriptors for each of those 9 generic professional capabilities. So by clicking on that box, the trainer can open all of the descriptors which lie under each of the 9 GPCs and can use those as the basis of filling in their comments in the box. So it really couldn't possibly be easier. It's really made out very, very, very simply for the trainers to complete. Next slide, please. So this just shows an example of what happens when you open the descriptor box, the orange box on the right-hand side. It gives you a list of the various descriptors for each of the 9 GPCs. And immediately you can see whether the trainee meets each of those descriptors or not. Next slide. As part of the multiple consultant report, there is also a report on the capabilities in practice. So again, on the left-hand side in the blue boxes, you've got the 5 capabilities in practice, and then there's a descriptor box, and then there's a box for filling in comments. Next slide, please. The trainees also are expected to perform a self-assessment prior to their ARCP. So the multiple consultant report provides the basis for tailored feedback against the outcomes of training, and this will be followed by trainees being given a dedicated feedback session by a lead clinician. But the trainees themselves will have a corresponding self-assessment to aid their reflection as well as discussion at their feedback sessions. Next slide, please. So where does the MCR, the Multiple Consultant Report, fit into the placement? Well, at the beginning of a rotation, there's a meeting with the assigned educational supervisor in which there is objective setting and an agreement on the learning which will be achieved during that placement. At that meeting, the MCR from the preceding placement, so the last rotation, is reviewed in order to set the objectives for the forthcoming placement. There's then a midpoint learning agreement review with an interim multiple consultant report. And then at the end of the rotation, there's a final review and an end of placement multiple consultant report, which feeds into the AES report, which in turn feeds into the ARCP. Next slide, please. So just to summarize, the GPCs and the CIPs are the new outcomes of training. The multiple consultant report emphasizes the professional judgment of trainers and captures excellence. It provides tailored formative feedback to trainees and informs the assigned educational supervisor report for the ARCP. The trainee self-assessment is exactly identical in format to the multiple consultant report. And the WBAs will be reserved mostly for critical conditions and index procedures. Next slide, please. So what won't change? It sounds like there's a huge amount of change, but the use of the WBAs will still happen for trainee learning, but they will be used more for formative assessment rather than summative assessment. The standard and content of training is not really changing at all, although there are some exceptions to that, particularly in the case of general surgery, and my colleague Paul Balfe will certainly be talking about that in a moment. The end point of training is not changing. The mechanisms for teaching and learning are not changing. The formal exit examinations are not changing. And the ARCP progression process is not changing. Next slide, please. So, although there are a lot of changes, the general look and feel of the intercollegiate surgical curriculum program remains the same. There is absolutely no doubt in my mind that the new intercollegiate surgical curriculum is the most elaborate, most robust, and most comprehensive surgical curriculum of anywhere in the world. Whether you look to North America, to Australia, New Zealand, or to anywhere in Europe, you will certainly not find a surgical curriculum as elaborate and as comprehensive as the ISCP in these islands. Thank you.
Thank you, Oscar. And as always, your presentation is absolutely cogent and logical and clear and easily to follow. Can we move on now to ask Amy Fowler, who's a specialist registrar, ST5 in vascular surgery, to give us the trainees' perspective. Amy?
Thanks, Prof. O'Connell. Can you all see my slides there?
Yes, thank you.
Perfect. So I'd like to thank the President and the RCSI this evening for giving me the opportunity to talk on behalf of ASSET. I'm Amy Fowler. I'm an ST5 in vascular surgery, currently working in University Hospital Galway, and I'm the Irish representative for ASSET and also one of their executive council members. So just for those of you who don't know who ASSET are, we are an independent professional body which works to promote the highest standards in surgical training. ASSET is the only body across the UK and Ireland to represent trainees at both core and higher surgical training levels and across all specialties. We work very closely with other trainee groups, including ISTG here in Ireland, who we are associated with and collaborate with frequently. The association represents the views of surgical trainees through representation on the councils of the Surgical Royal Colleges, ISCP, JCST, and numerous other working parties and committees. Unlike many other junior doctor trainee groups, we remain independent of the Surgical Royal Colleges and other professional medical organisations, and we're run by trainees for trainees. So our role in curriculum negotiations was that we provided a trainee voice and we advocated for trainee choice as part of the discussions. We contributed to proposals and highlighted areas of concern specific to each region and specialty, which were highlighted by our members on council and trainees within our regions. Our main focus in these discussions was in maintaining trainee choice and ensuring that modules were not introduced for workforce purposes only. We were involved in multiple discussions and we were invited to those discussions with the 4 Royal Surgical Colleges, and we provided input and feedback to JCST on the decision-making process. Our aim in the end was to ensure the endpoint of training was not diluted and to safeguard specialty training, and I think it's safe to say that I think we have all collectively achieved that with working with all these other key stakeholders. So I think Prof Trainer has covered a lot of this, but the new curriculum, to give an overview, will become outcomes based. So the new curricula should describe fewer outcomes, which will be generic, high level and specialty specific. Training will now be based on a trainee's capabilities in areas required for them to become a consultant. The end of training will be reached when supervisors agree that a trainee is performing to a level of a day 1 consultant. Now, a day 1 consultant level does not mean full independence in practice and is specific to the specialty syllabus, but a day 1 consultant are expected to perform the usual weekly practices. They aren't expected to do every complex or unusual procedure independently or to manage every complication independently, and there is a recognition that this comes with time and with mentoring following certification. With this new curriculum comes a new assessment form, the multiple consultant report, which encompasses the concepts of generic professional capabilities, which we can see here on the left, and capabilities in practice, which we can see on the right. As Prof Trainer mentioned, the GPCs provide a thorough breakdown of tasks and areas for development, which apply across any medical specialty and are the basic requirements for medical practice. The CIPs provide an overview of the general domains a day 1 consultant should be competent in. These were informed by the GMC report Excellence by Design, which recognised that our current assessment system is often too detailed and too granular, and the previous WBAs were good at assessing particular tasks or assessment of conditions, but did not really provide a holistic approach to assessment and centred on tasks that are far too small to give an overall judgment of a trainee's capability. For trainees, we believe that this process should provide a more specific individual action plan and should be more informative going forward. The new curriculum has changed some of the goalposts, and there have been changes to indicative numbers which trainees need to be aware of. It is crucial that trainees read their new curriculum and become familiar with it. Training will now be arranged in phases with general indicative timeframes, as Prof Trainer mentioned. The new curriculum provides the ability to gain experience in special interests within a specialty, which is a particular positive. Using general surgery as an example, the inclusion of endoscopy numbers facilitates and ensures ongoing access to endoscopy, which should ensure that trainees reach targets for JAG accreditation, although it won't mandate JAG accreditation. Subspecialty trainee has been retained, and this was one of our main focuses in our discussions with the JCST. New curriculum options will also give trainees more choice, for instance, addition of a trauma subspecialty, and there is emphasis on emergency general surgery as part of the curriculum where there hasn't been previously. As we mentioned, there is now a new assessment process. Using the GPCs and CIPs, learning agreements should be aligned towards the trainees' progress and their own development. The learning agreement process will be similar, with an initial learning agreement within the first 4 weeks to focus training for the year. The initial learning agreement should be informed by the previous year's ARCP and MCR, and it should highlight very specific areas for that trainee's development. A midpoint MCR should then be completed in the middle of the training post by at least 2 clinical supervisors who discuss progress and form an assessment together. And following on from this, a midpoint review and learning agreement should then be performed, taking this midpoint MCR into account. This should be informal and formative, and it should provide feedback for the trainee to create a specific individualised training plan going forward for the year to make sure that targets are being met. At the end of the placement then, another MCR should be completed, and a trainee self-assessment should also be completed. And as these follow a similar format, these can be directly compared. These are then used to inform the AES report and the ARCP. As with anything, of course, this will have an impact on trainees. And with any new system that comes into play, there are potential benefits and pitfalls. We believe, and the most positive thing to come out of this new curriculum is that this should provide a more flexible training programme. Whilst there are broad indicative timeframes that will be applied, the new curriculum will allow trainees to progress faster if they demonstrate excellence and capability. If trainees are progressing at pace, they should be facilitated to finish early, and the opposite should apply for trainees who need more time and flexibility, that they should be afforded this. The current WBAs provide building blocks, which can be assessed at the end of training. However, it doesn't really give a good overview of trainee progress across domains. There might be holes in training which can be very difficult to pinpoint. With the new WBAs, there's no minimum annual requirement, and this will shift the focus away from the usual tick box exercise and hopefully will move this towards a more meaningful assessment. WBAs will now be focused on critical conditions and index procedures specific for that specialty's curriculum. This will allow for continual comparison of trainee stage against the endpoint of training and should help the trainee progress along the right path. The GPCs then provide a more holistic approach, and if a trainer has concerns or a trainee feels that they're not developing in certain areas, they can select a small number of descriptors to specifically highlight this and pinpoint areas that they need to develop. As mentioned, there are potential pitfalls with this new curriculum. It requires trainer familiarity with the process, and it requires trainer buy-in. The MCR is a global professional judgment of different skills and behaviours to make decisions about a learner's suitability to take on particular responsibilities and tasks that are essential to consultant practice. With that, and for that, trainer input is required. It requires a very good understanding of the syllabus, the GPCs, and the CIPs. The MCR must be carried out by consultant clinical supervisors involved with the trainee and with AES contribution. There must be no fewer than 2, and they must meet and agree upon the MCR, and this could be a potential pitfall in trying to arrange these meetings. As mentioned, this curriculum was developed around a UK-centric approach. It was in response to 2 GMC reports, and it was approved by the GMC with the UK framework. However, there was input, of course, from RCSI and from the IMC, and it will be adopted here, but I think it's important to bear in mind that this has to be adapted to our own system, which is very similar to the UK, but does have some differences. Another potential pitfall is that the ISCP is not currently used at the CST level, and there is supposed to be continuum between phase 1 and phase 2 in training, and this is something which potentially needs to be considered going forward. The new curriculum may also present some EDI issues. It will be new for the ST3s coming on to the pathway. However, for established trainees, the goalposts are changing, and these trainees will need facilitating to ensure that they meet the new requirements. This may be particularly relevant to trainees who are undertaking less than full-time training or who have extended training. It may present issues with obtaining targets when the targets are frequently changing. Going forward, ASSA advocates for trainers to familiarise themselves with the process so as to provide support to trainees, and this needs to be done before the introduction of the new curriculum and not on day 1. Learning agreements must be used and must provide a specific plan of action for the trainee with respect to their individual process, and I think this could be a really positive aspect of the new curriculum and the new assessment process. Trainees and trainers must ensure that they're familiar with the curriculum and assessment process before its introduction. There is a lot of jargon and a lot of processes which can be difficult to break down. There's a number of particularly useful resources on the JCST YouTube channel, and there are Ask Keith webinars which are available and are very useful in order to break this down. And once it is broken down, it is very easy and straightforward, and I think will actually prove much more useful than the current format of the training programme. So thank you very much for allowing me to talk, and I'll answer any questions at the end.
Amy, thank you very much. And it's great to know that there is buy-in from the trainees, that you've had a lot of input into it, and that the general sense is that this is a positive initiative. So that's really good to know. Please do send in any questions on the meeting chat, and we'll use them to have a discussion at the end. And now, can I ask Paul Balfe, known to all of us, and Paul, we look forward to hearing you.
Thanks, President. Can you see my slides there?
I can see myself on them anyway.
Oh, that's great. Are the slides up yet?
Yep. If you go to slideshow now.
I will, yeah, thanks.
That's good. Thanks, Paul.
Okay, everyone see that. Thanks. Well, good evening, everyone, and thank you, President, for the invitation to speak here this evening. Rather than consider the implications of the new curriculum purely from the perspective of the trainee or trainer, I thought it best to look at things from the point of view of the specialty of general surgery itself. And within that, of course, consider the implications for trainees and trainers alike. The specialty of general surgery is a very broad one, embracing as it does emergency and elective surgery, malignant and benign disease, adult and pediatric surgery, all body cavities, and scope on the part of practitioners to develop an area of special interest such as breast endocrine, colorectal, HPB, esophagogastric, etc. The broad range of competencies of the general surgeon has meant that more often than not, we are, or certainly were, the first to be called and first on the scene in the event of an emergency presentation. All of you will be familiar with the current structure of general surgical training, ultimately leading to CCST, involving, as it does, 2 years of core surgical training, followed by 6 years of higher surgical training with program flexibility to pursue a higher surgical degree such as an MCH, MD, or indeed a PhD. Oscar and Amy have already given excellent, succinct overviews of how the new curriculum has evolved over the years. Those involved in developing any curriculum, let alone one so diverse and complex, will attest to the considerable challenges involved. As Oscar mentioned, the previous curriculum was only published in 2013. It was over 350 pages long and was updated as recently as 2016. It's therefore worth considering for a moment some of the deep concerns and drivers that provided the impetus for the development of the new curriculum. Firstly, there was a growing concern that the pursuit of a chosen elective special interest was increasingly taking precedence over general emergency and elective competencies, and many would argue even at the expense of these competencies. Practitioners were and are increasingly defined by their elective special interest, with general competencies and most especially emergency competencies taking a back seat, or indeed no seat at all. On the specific issue of emergency general surgery, we are reminded by the ISCP, which stands for Intercollegiate Surgical Curriculum Programme, that it represents 50% of total general surgery workload, and that emergency general surgery is not simply elective surgery performed out of hours, but is fundamentally different, requiring different approaches to investigation, decision-making, patient optimization, and choice of operation, and as such, there's an imperative that those providing emergency general surgery be properly trained and supported. It was recognised too that the separation of the subspecialty of upper GI into two separate streams of esophagogastric and HPB was long overdue, that there was a need to formally provide for transplant, oncoplastic breast, and general surgery of childhood, and I would add surgery of the pregnant patient into the mix, and that training and service needs arose from the ongoing rollout of trauma networks, which has been underway in the UK since 2013 and more recently in Ireland with the publication and ongoing rollout of a trauma system for Ireland. In the broadest sense, the new curriculum seeks to align with the requirements of patients, the population, and health service strategy, and more specifically seeks to re-establish the specialty centre of gravity as emergency and elective competencies across the generality of surgery. The new curriculum was scheduled for implementation in 2020, but its implementation was deferred until now due to COVID-19. The RCSI will in fact be the first of the 4 Royal Colleges to begin its implementation at the annual changeover on the 12th of July next, which is a month ahead of the UK. The most obvious feature of the new curriculum is that elective and emergency general surgery are once again front and centre. You'll also note that all trainees will be expected to rotate through both upper and lower GI, which isn't always the case at present. Trainees will still be expected to pursue a special interest, but it's emphasised again and again that this is in addition to the emergency and elective general modules. Each module of the new curriculum has associated with it a series of competencies which are divided into knowledge, clinical, technical, and professional. While all trainees are required to complete the mandatory modules in emergency and elective general surgery and attain the specified competencies, a new special interest option of trauma surgery has been introduced. And thankfully, a number of our higher surgical trainees have already expressed an interest in pursuing this option. Indeed, one of our ST8 trainees, Mr. Gary Bass, who presented at the charter meeting earlier in the year, is currently doing a trauma fellowship in the US. But now there will be a formal pathway for other trainees to do likewise. The new curriculum recognises the implications for training arising from the ongoing rollout of a trauma network for Ireland. It's a hub and spoke model whose main features involve the establishment of 2 major trauma centres, one in Dublin at the Mater University Hospital and the other in Cork at Cork University Hospital. Hospitals which have the core 4 specialties of emergency medicine, anaesthesia and critical care, general surgery, and trauma and orthopaedics will be considered for designation as trauma units. There will be up to 10 of these throughout the country, with 2 in Dublin, one at Tala University Hospital and the other at St. Vincent's University Hospital. Hospitals currently on emergency take, but which do not have a trauma and orthopaedic unit on site, or in the capital who are not one of the designated trauma units, will not be part of the new trauma network, but may still receive non-trauma emergency general surgery such as acute appendicitis, perforated viscus, etc. The core trauma team in a designated trauma unit will comprise emergency medicine, anaesthesia critical care, trauma and orthopaedics, and general surgery. It makes sense, therefore, that the training programs be aligned to the predicted needs arising from the rollout of the trauma network. Currently, over 60% of surgical and medical NCHDs are not on any formal training program. Similar to the unreliability of stamp duty as a core pillar of government fiscal policy in the past, reliance on overseas doctors as a source of medical personnel into the future is similarly unreliable. More importantly, though, it's also unfair. We have also witnessed the ongoing brain drain of Irish medical graduates, including a considerable number of CCST holders. In this way, despite the enormous financial, training, mentoring, and nurturing resources deployed in getting our trainees to the highest level of competence, the bounty or benefit is unfortunately harvested by other jurisdictions. We simply have to find a way to stem this hemorrhage. As to the future structure of the surgical team, we saw from last week's webinar that this will comprise one or more consultants, a number of NCHDs, all of whom will be on a training scheme, physician assistants or physician associates, advanced nurse practitioners, and clinical nurse specialists. Similarly, given that there seems to be all-party consensus that Sláinte care represents the blueprint for healthcare into the future, consultant appointments will increasingly be to a network of Model 3 and 4 hospitals, offering scope to the appointee to practice the breadth of emergency and elective general surgery, as well as pursuing their own area of special interest. There are already good examples of this in action, and I point to examples like Mr. Des Tooney and Professor Kevin Barry. This will lead to a more equitable distribution of surgical skills and talent across the population as a whole. It follows, therefore, that as a specialty and as a college, we have a to-do list. The General Surgery Training Committee, together with the Department of Surgical Affairs, will help both trainers and trainees transition to the new curriculum. Trainers and trainees, for their part, will need to educate themselves as to what's expected of them under the new program. And already there have been a number of excellent webinars arranged by the ISCP. The ISCP website itself is also an excellent resource, which can be referred to at any stage along the way. Mr. Ken Mealy gave an excellent presentation at the Charter meeting earlier in the year regarding the progress on finally separating emergency and elective work streams under Sláinte care. It's no longer tenable that senior surgical personnel on call have simultaneous elective commitments that may even involve an elective theatre list off-site. The college will need to develop and enhance training modules for higher surgical trainees and for what are termed non-training surgical personnel involved in the delivery of emergency and trauma care, as well as post-CCT surgeons. And because of the interdependence between certain specialties, we will need to ensure that formal and informal collaboration between specialties, which in practice live in each other's shadow. Training is ultimately deemed complete when supervisors agree that a trainee is performing at the level of a day one consultant capable of managing the unselected emergency take and more besides. It would seem reasonable that the litmus test, insofar as emergency general surgery is concerned, is if at the end of the training program, CCST in hand, you can be safely dropped into a trauma unit as the general surgery constituent of the core trauma team and competently deal with what's described in the new curriculum as the full range of emergency conditions in the generality of general surgery. In conclusion, we are at a crossroads in so many ways, and the almost contemporaneous publication of these three seminal policy documents points the way to a surgical service and indeed a health service that more equitably serves the needs of the population as a whole. The college, i.e. us, can have, if we choose, a major proactive role in ensuring that this aspiration becomes a reality. I would like once again to express my thanks for the invitation to speak to you this evening. And of course, I'll be happy to take any questions in the Q&A session at the end. Thank you.
Thank you, Paul. very important contribution, and I think you get to the core of the needed outcome, particularly in terms of the generality, not just of general surgery, but I suspect that this will apply across all disciplines, which brings me to a question from Rory McConnon-Walsh, who compliments the presenters. For those trainees who wish to become generalists and not subspecialists, does this mean that their training will be shortened, assuming they fulfill the required outcomes? If they get through the critical progression point and have met all the metrics needed to be a day one generalist, do they need to progress into phase 3? Perhaps Oscar might take that.
Yeah, well, that's really feeding into the concept behind the shape of training, or the Greenaway report in the UK. That's not what's intended with the new curriculum. The new curriculum is still an indicative 8 years, encompassing 3 phases of training, the final phase being years ST7 and ST8. So within the new curriculum, there is not a plan to reduce surgical training for those who do not wish to take subspecialty area of training. That may come in the future down the line, but it's certainly not part of the new curriculum at the present time.
And this brings me to the issue about the critical progression point. Are we introducing another chicane in terms of training, or is it a point at which that in order to progress you need to have the intercollegiate fellowship?
No. The critical progression point is definitely not a further selection process. They're very, very adamant that they don't want to introduce a new selection process. We already have selection into core training and then a further selection into phase 2 training. What it is really a rigorous review of progress. So by the end of ST6, prior to entering the final phase, trainees should have achieved level 3 supervision in all of the CIPs and the GPCs. That's really what they mean by a critical progression point. They must have reached that supervision level in all of the CIPs and the GPCs. They don't have to have passed the FRCS exam. In fact, they can't do the FRCS exam until they have achieved a satisfactory outcome in their ARCP at the end of ST6. So it's anticipated that they are ready to do the exam, but they're not actually eligible to do the exam until they enter the final phase.
Okay, Rick Pretorius, there's a high need for generalists in Ireland based on the need of Model 3 hospitals. Can improving Model 3 services lighten the load on centres of excellence for more complex cases? And he wants that addressed by the whole panel. I think the sense I get is from, and maybe we might get Paul to address this. The sense is that future appointments, having come through this process, will be to the network, and that involvement in both Model 3 and Model 4 services is what's envisaged. Paul, is that what you think?
Yeah, it's not what I think, President. It's actually what is going to be the case. That will be the new policy into the future, that no longer will you have your appointment to a building, which is ridiculous when you think about it. You will have your appointment to a population base in the form of a network. So you'll service the needs of Model 3 and Model 4. And in that way, such as Des Toomey does at the moment, or Kevin Barry, or indeed Jerry McEntee and John Keneally, who do a list up in Navan, I think, as far as I know, your skill set will be deployed across a much broader population base.
Amy, what's your view on this? Because right now, the ST8s and they're all looking to go abroad to do subspecialty fellowships. I think we had something like 16 applications for the traveling fellowships. Is there a sense amongst the trainees now that perhaps good enough is good enough, and you don't need to spend many years doing subspecialty training that you're probably not going to be able to use when eventually appointed?
I think the most important thing from a trainee perspective is to have a choice, and I think that approach of being appointed to a region provides that choice rather than being railroaded into kind of a certain kind of hospital or a certain level of work that they're not necessarily happy to do. So I think the most important thing is that trainees are afforded choice with their options, and certainly the new curriculum provides that choice. We're still maintaining specialty training, but as Mr. Balfe mentioned, there's a focus on emergency and elective general surgery, which is an important component of general surgery specifically.
Could I just come back on that? I mean, if you're talking and you're raising a very important point about emergency general surgery, and I'm using general surgery, it will be emergency general orthopedics or ENT or urology. How is it possible for somebody appointed to a network to deliver that kind of care across the network? Surely you have to be linked to one of the units within the network, be it a level 3 or a level 4 hospital, as your base.
I assume that would be the case, but as mentioned, I suppose that at present there are opportunities for consultants to still uphold some amount of specialty work, even if they work in a Model 3 hospital. As Mr. Balfe mentioned, you know, that those consultant appointments do exist at the moment, and I think they work very well for consultants who choose that particular route.
Paul, could you come back on that?
Yeah, Mr. President and Amy, good points raised there. That's exactly what's envisaged, and there are already good examples of this in action. For example, Professor Barry is linked to, for his general elective and emergency work in Mayo University Hospital, and yet pursues his special interest work up in University Hospital Galway. Similarly with Des Toomey, who again is associated and linked with Mullingar University Hospital, but does his colorectal work up in the Mater. When I was in Kilkenny, I was offered the option of doing my upper GI work in Vincent's, elective upper GI work, and yet doing my emergency and elective more general work in Kilkenny. This can readily be addressed. It's not an insurmountable problem.
It's probably not something really for this webinar, but of course this does beg the difficulties of continuity of care. But perhaps that's a different different agenda.
But I don't agree with you there, President. That happens anyway. You know, I mean, there's lots of occasions, as you and I know, where cases are done and may not be seen by the consultant for days after the operation is performed because they have commitments off-site in other institutions. Similarly, if you're along the model of Des Toomey or Kevin Barry, you spend a day or a day and a half in the Model 4 hospital attending to your special interest area while you have the rest of your time in the Model 3 hospital. So I don't.
I think we could probably have another webinar on this issue. But can I get back to Oscar, and how will this work with less than full-time training? Because it does seem to be a very intense continuum.
It is an intense continuum, but the emphasis going forward is really going to be on achievement of competencies. It's going to be an outcomes-based curriculum rather than time-based. And I think undoubtedly people who reach their competencies will get signed off. And so for people who are doing less than full-time training, I don't think it's going to be as much of an issue as it has been in the last, say, 10, 15 years, because once they achieve their competencies, it doesn't really matter how many years they've spent in training. It's going to be outcomes based.
Unless, of course, they lose that competency if they've taken such a long time. So is there opportunity to revisit competencies, or is it, again, once you've got the chitty, you've got the chitty?
It pretty much is at the moment. That may be an issue which raises its head over the coming years, but at the moment you're absolutely right. Once you've achieved your competency, that's it. You've been signed up.
I'm not thinking particularly of paternal or maternal leave, but I'm thinking of somebody who takes maybe 2 or 3 years out to do a PhD during their time in phase 2, which we're trying to encourage as well. I mean, it does really raise the question of whether or not competency reassessment needs to be undertaken.
Yeah, I think that's a very important point.
Okay, well, if they're still on the program,
things.
Mr. President, I mean, that can be done at any stage. If they're still on the program and they've taken out time out of phase 2, they have to complete then phase 2 and also complete then phase 3. So once they're still on the program, it's up to the trainers and supervisors to ensure that they have the level of competency required before they can be signed off.
Dermot Hare, does the panel have any comments on current situation where there are many vacant consultant posts or very few applicants?
Yeah, this is a really thorny issue. And there are multiple reasons why there are vacant consultant posts at the present time. Many people on the webinar this evening will be aware that NDTP have a very ambitious plan for increasing the number of consultant posts by 2028. That's just 7 years from now. They plan to have a 35% overall increase in consultant numbers by 2028. And they have asked all of the training bodies to increase the pipeline. In other words, increase the number of trainees in order to achieve that goal by 2028. Here in RCSI, we've already started that process. We've increased the intake into core surgical training this year from 60 to 80, which is a 33% increase. And that will happen each year going forward, so that by the year 2028, we will have an overall increase of 35% in the number of trainees who are reaching completion of training. So there will be more trained surgeons to apply for consultant posts. But of course, that doesn't necessarily mean that they will apply. There are many reasons why people are not applying for consultant posts in this country at the present time. And that's probably an area that is too vast to go into this evening.
I agree, but just in passing, Liam Joyce has put in that joint departments just don't work and are unsafe. I'm not sure everyone agrees with that, Liam, but I think it is a valid point, and maybe one of the reasons why people don't look to apply for level posts which are in level 3 hospitals. Rick Pretorius again, would RCSI provide the trainer course to provide equality among trainers assessing trainees based on the new system? I think that's being put in place, Oscar.
Yes, it has. And there's absolutely no doubt that we are going to be required to do a lot more in this area. So as you know, we operate under license, if you like, from the Medical Council. The Medical Council is the regulator. And the Medical Council have made it very clear to us recently that they expect all of the training bodies to do a lot more in terms of professionalization of training and providing more supports, educational supports and training supports for trainers.
Jesse Elliott, thanks to all for the informative presentations. Just a few practical questions. How does the new curriculum deal with trainees who take time out to do research? Jesse, I think we've addressed that. Do trainees obtaining a PhD or MD in phase 2 gain any credit towards their years in training? I don't think so. Oscar?
No, surgical training now has been so streamlined and so shortened, if you like, that it really would be very difficult to give credit for time spent out of program in research. People need all of the clinical training, all the clinical experience that is provided. It's a real challenge to even get it into 8 years. So it would be difficult to give credit in lieu of clinical experience for research.
And if you were super duper and had all your chitties, as we've said, could you get through phase 2 in 3 years rather than 4? As you've said, it's an indicative number.
Yeah, absolutely. That is the concept behind the new phases, that they are indicative periods.
And of course, Helena Rowley has brought in, I think in cricketing terms, it's a googly. Does anyone have a concern that a day one consultant is an experienced registrar by another name? Well, I think the day one consultant always was an experienced registrar who just had gone on to the next level. I don't know, Paul or Amy, if you have any.
No, I'd agree with that. Like, I mean, there's going to be no diminution in the level of competence. In fact, if anything, it's going to be increased because of the new outcomes-based approach. You cannot be signed off unless you're considered ready for the job. And that hasn't always been the case. We had our higher surgical training meeting before this webinar this evening, and it was mentioned during it that in the UK at the moment, there is an unprecedented number of young consultants out on gardening leave, because most of them, if not all of them, have gotten into trouble with emergency cases at which they were out of their depth. And the head of the BMC, who addressed our committee in recent years, has said that Scotland Yard are now looking at who signed them off.
Well, thanks for that cheery note, Paul.
No, it's an important note, Ronan. It really is. We have to ensure, which the new curriculum seeks to do, that people are only signed off when they're ready. And that's not only good for the patient, it's good for the practitioner as well.
Can I venture that actually what we should probably be doing is what they do in North America and in many places in Europe, is that a day one consultant isn't an independent entity, but that the day one consultant is part of a team with perhaps some older surgeon, and I don't need to look very far, looking over their shoulder.
You're on, Ronan. You're on. We've a new job here. No, I agree. No, I think that would be a very wise idea. And when I spent time in Texas and in upstate New York, that's exactly what was the case. People didn't feel thrown in the deep end on the first day. And that sort of nurturing and mentoring is something myself and Oscar have spoken about it regularly, that we will need to, in the fullness of time, make part of the landscape in Ireland here as well.
Okay, one other question. What about academic surgery stream? Well, I think we need to ensure there is an academic surgery stream. We're working on developing that pathway, but I think it is inevitable that it will increase the length of training, as you've heard from Professor Trainor. I'm going to bring it to a close. I'd like to thank Oscar, Amy, and Paul for a really very informative session. I would urge all of you to engage in this and maybe look at the ISCP website and to download the curriculum. It's a big document, but it does give a lot of what you have heard tonight, and many of the infographics that you've seen tonight have been taken from that document, and so it's very useful. I'm sorry if we have talked more about general surgery than other disciplines, but I think the curriculum changes are right across all of the specialties. And just to say to our speakers, if you haven't looked at the chat, there are lots of thank yous coming in to thank you all for your presentations. So thank you all and good evening.